السلام
إيمان
عليكم.
ازيك؟ سلام كده. سامعني كويس؟ الو؟ سامعاني يا شباب؟
ايوه سامعني قطع.
ماشي تمام اوكي.
ممكن اللي فتح الكاميرا يقفلها.
السلام عليكم، ازيك يا طه؟
ازيك يا شيماء، ايه الاخبار؟
السلام عليكم دكتور شيماء، ازي حضرتك؟
ازيك يا عمر، ايه الاخبار؟
ازيك يا باشا، عامل ايه؟
الحمد لله. صوت كويس؟
انا
ازيك؟
مستمعة.
تمام زي الفل.
انتوا
ماشي
سامعيني
بقى.
طيب؟
سامعينك كويس. انت سامعانا؟ شيماء مش سامعانا.
انا مستمعة ليه؟
عمر you can share your screen بقى لحد ما الناس تبدأ تجوين. ماشي؟
تمام يا باشا.
دكتورة شيماء. دكتورة شيماء. انا صوتي واضح يا دكتور عمر؟
انت صوتك زي الفل، واضح جدا. دكتور انس، ازي حضرتك؟
السلام عليكم، ازاي الصحة؟
عليكم
الله
السلام.
يسلمك يا دكتورة آن، ازي حضرتك؟ ايه الاخبار؟
الحمد لله الحمد لله، كل بخير الحمد لله.
الله يكرمك دكتورة آن. اهلا
في يا رب كده ان شاء الله يبقى ميتنج موفق وجميل بإذن الله.
ربنا يخليك يا دكتور آن، بوجود حضرتك. الله يكرمك.
انتوا يعني ما شاء الله عليكم، يعني كله فيكم الخير والبركة يا رب ان شاء
ربنا
الله.
يبارك في حضرتك دكتورة آن، الله يكرمك.
جديد عليا السوفت وير ده.
سامعني ازاي؟ انا قفلت دلوقتي. انت فاتح المايك قفلته. لا انت بس اللي عندك المشكلة.
لا المايك مفتوح على فكرة، المايك بتاعك مفتوح.
مايك مفتوح
مم.
انت بس اللي مش سامعينك يا شيماء. سامعة دكتورة آن؟
سامعاك كويس قوي، الصوت واضح جدا.
دكتورة آن سامعاني كويس. انت بقى ايوه ودكتوره انسه معاني انا. ماشي اوكي. معلش دكتوره انا بس دكتوره شيماء عندها شويه تكنيكال ايشوز صوتها هي مش سامعانا
اه لك هي خليها تطلع وتدي اوردر للبروجرام انها تخش بالميكروفون. مش
الميكروفون
هتسمعنا
صح؟
غير لما تدي الاوردر ده.
اوكي
خليها تطلع وتدخل تاني.
اوكي. كده سامعاني؟
يعني لو دكتور شيماء لسه مش سامعانا، ممكن يبقى عشان ده ابلكيشن مختلف، فهي she has to tap into a different mic. يعني لو كان طلع لها كذا اوبشن كانت ممكن تدوس مايك مختلف، او هي داست مايك مش شغال.
انا بقول لها كده بس ماشي اوكي.
دكتورة شيماء عرفت تدخل؟
I think ان هي خرجت وهتساين ان تاني I'm not sure.
بس الميكروفون مفتوح دلوقتي.
لا هي leaving
عندها التليفون مفتوح. خرجت
خرجت. اوكي احنا يعني we'll wait for 5 minutes لحد الناس تجوين and then we can start ان شاء الله.
اوكي ان شاء الله.
Hello, everyone. We will start in 1 minute. We'll just give some people opportunity to join. Okay. Good evening, everyone. Welcome to the second multidisciplinary team meeting in our Indo-Egyptian SEEG week. My name is Dr. Omar Adel Hassanin. I'm an assistant lecturer of neurology at New Giza University. It's my great pleasure to be moderating this session. As many of you know, this series is building toward our main event, the Indo-Egyptian Stereotactic Epilepsy Surgery Week, which will take place later this month, starting November 24th at Town Hospital, New Cairo. For our colleagues in Egypt, this is, of course, like a particularly proud moment, as this is a collaboration that represents the first dedicated SEEG program in the country. This historic week will feature Egypt's first ever SEEG implantation and a comprehensive SEEG masterclass covering planning, trajectory design, signal interpretation, and stimulation mapping. And today's meeting is the second of 3 online meetings designed to prepare us for this landmark event and to strengthen the foundations of the epilepsy surgery across Egypt and the Middle East. So tonight, our focus is on the main challenges that faces epilepsy surgery. We will be discussing 2 complex cases of drug-resistant epilepsy, both featuring extensive or multifocal lesions near highly eloquent cortex. And the central question we will be exploring is how can SEEG help us distinguish a resectable dominant focus from a widespread network? And when does the data point us to away from the resection and toward a palliative or neuromodulatory strategy? It's a complex discussion, so we are incredibly fortunate to have a world-class panel to guide us. So we're deeply honored to have with us tonight 3 distinguished faculty members from Glen Bliss Hospital and Darela Hospital in India. Darela Center has performed over 400 SEEG cases and more than 150 hypothalamic hamartoma radiofrequency ablations, making them one of the most experienced epilepsy surgery programs in Asia. First, we welcome Dr. Dinesh. Dr. Dinesh is the Director of Neurology and Program Director of the Advanced Center of Epilepsy at Glen Bliss Hospital. He is a leading figure in epileptology with advanced training at King's College London, specializing in intracranial EEG and video EEG monitoring. Dr. Dinesh has performed over a pre-surgical evaluation of over 2,000 drug-resistant epilepsy patients, and his team has since completed over 200 epilepsy surgeries. We're also honored to have Professor Natation. Professor Natation is a senior consultant neurosurgeon specializing in epilepsy surgery and functional neurosurgery at the Amrita Advanced Center for Epilepsy. Professor Natation is known for his advocacy and commitment to community service, epilepsy camps, and awareness programs across India. And completing this team, we welcome Dr. Arun. Dr. Arun is a consultant adult and pediatric neurologist and epileptologist at Gleneagles Hospital. His dual training in pediatric and neurology brings unique expertise and will actually be invaluable for our first case tonight. So, professors, we thank you tonight for joining us. We're delighted to have you. Of course, I'm equally proud to introduce our senior Egyptian faculty members. First, from the neurophysiology and neurology panel, we have two distinguished professors who, to everyone here, truly need no introduction. We are honored to have Professor Dr. Anne Abdelader. She is the professor of clinical neurophysiology at Cairo University and the president of the Egyptian Clinical Neurophysiology Society. Dr. Anne is known to us all, and we are so grateful for her leadership in the field. And we're equally honored to have Professor Nermeen Adel. She is the professor of neurology at Cairo University, the director of the Australian Epilepsy Clinic. Dr. Nermeen is the vice secretary of the Egyptian chapter of the International League Against Epilepsy. And from our distinguished neurosurgery panel, Professor Ahmed Ali Morsi from Zazi University, Professor Ala Rashad from Al-Azhar, Professor Basim Ayoub from Cairo University, Dr. Muhammad Ashraf, lecturer of neurosurgery at Ain Shams University, Professor Muhammad Fathi from Al-Azhar University, Professor Muhammad Gabr from Cairo University, and Dr. Sameh Hamdi, lecturer of neurosurgery at Cairo University. So thank you all for dedicating your time and expertise tonight. Okay. Just before we begin, just a few things we have to say. We're gonna today's agenda is we're gonna be discussing two cases. There are gonna be two case presentations, each followed by a panel discussion and an audience Q&A. You can, of course, to anyone who wants, you can enable the live caption options, so you can see a live transcript of the presentations and the discussion. You can just click on more on the Teams app, and you then click on live captions to turn it on. You can leave your questions in the chat box, or you can post your questions in during the Q&A segment as well. Okay. Now let me introduce our first case presenter, Dr. Ahmed Taha Al-Qiyai. Of course, many of you know Dr. Taha, but for those who don't know, he is truly the driving force behind the Indo-Egyptian collaboration. His vision and tenacity to make this work is truly inspiring. His case tonight, the first case, he will present us with a pediatric post-encephalitic patient with extensive left frontal encephalomalacia that's encroaching upon the subcentral area, the anterior insula, and the basal ganglia. And to add to this, the functional MRI places the Broca area immediately anterior to that lesion, and the motor cortex lies in close proximity. So the dilemma, or the clinical dilemma, will be: is this entire region epileptogenic, or is there a dominant focus? And can we resect safely without devastating language or motor function? And should we wait for a formal drug resistance, or is early intervention justified in a developing brain? Dr. Ahmed Taha, the floor is yours.
Thank you so much, Dr. Omar, for your great introduction. I will start sharing my presentation. Can you see my screen now?
Yes, we can see clearly.
Okay.
Yes.
Okay, so thank you so much for your presentation, and thank all the panel, for the Indian and the Egyptian panel, for joining us. Today, I will be discussing a case. It's a Rolandic semiology with an extensive left frontal insular lesion. He is a male, 10 years old. The age of onset of seizures is 9.5 years, so that was 6 months ago. He's doing very well at school, highly performing. He's right-handed, negative consanguinity. There's no perinatal history, unremarkable perinatal history. Past history is really unremarkable, except for a history of a febrile illness at the age of 7 with mild disturbed conscious level, but no imaging or LP or any investigations were done. His seizure semiology is he gets an aura, but he's not able to specify it. So it's kind of an unspecified aura where he waves to the parents, as you will see during the home videos and the video EEGs. Then there is a bilateral perioral clonia that if you really concentrate, you will see it a little bit more prominent on the right side. Then there's very prominent silurea and motor speech arrest. He's not able to speak because of the motoric manifestations happening in his face. Currently, he's controlled on carbamazepine. And because of this semiology, he was initially diagnosed as Rolandic or selects. Interictal discharges, they were bilateral independent centrotemporal discharges that were more prominent on the left side. You can see this is the average montage. And in the average montage, you can see left centrotemporal spike and wave discharges. Here in this epoch, also in the average montage, you can see discharges on both sides. Initially, in the first second, there's right centrotemporal spikes, and on the following second, you can see it discharges on the other side. So it's evidently bilateral. Again, you can see bilateral independent discharges. Okay, so this is an epoch of the ictal EEG. I'll show you the ictal EEG, okay, the video EEG itself, but it just shows, if you can appreciate, a left temporal delta discharge, which is usually the electrical onset of the seizure. Okay, actually the home videos are very illustrative. You can see that he is aware, he's conscious, he's responding to his mother. The mother is asking if you can hear him, and then you can see the silurea. Now he can speak, but he's a little bit dysarthric. You will appreciate the clonia. It's bilateral, but it's a little bit more prominent on the right side. Just a subtle difference, but it's mostly bilateral. Of course, you can see the silurea. Again, he is conscious. This is the video EEG. We recorded 3 seizures. This first seizure, the onset seems bilateral, but it's more prominent on the left side. But in the coming seizures, it will be more prominent on the left side. You can see the rhythmic delta activity that is evoluting beautifully in both hemispheres. The clonia started, but it might not be very evident. The technician is testing him, and he's evidently conscious and responding to vocal and motor commands. This is another seizure, and you'll be able to appreciate the ictal onset is coming on the. This is an average montage. It's very evident on the left temporally in T3 and T5. You will see rhythmic delta activity followed by evolution. You can see it here. It's starting here in the T3 and T5, then spreading. Again, he's waving for his mother. Then the clonia starts. Again, he's responding. There's no weakness. This is another seizure that happened out of sleep. Again, same semiology with the same ictal onset. Again, on the left temporal leads, you can see the T3 and T5. So regarding his MRI, I will show you the MRI, but this is the report. It shows gliosis encephalomalacia in the left and inferior and middle frontal gyri, reaching the subcentral cortex and the anterior part of the insula. And there's also gliotic areas in the left putamen and left caudate. So this is on the left side, sagittal flare. You can see the hyperintense signal. Again, the insula is affected. You can see the insula and the frontal operculum affected. Subcentral. We did functional MRI, and this is the antonym task. It's bilateral, but it's again more on the left side. Story listening task is on the right side. So in short, the irritative zone, as we always think about in epilepsy, we need to put the anatomo-electroclinical correlation. So if we think about our zones, our irritative zones, which are the interictals, we have bilateral centrotemporal irritative zones. The ictal onset zone, which is the ictal EEG, is left temporal. We do not have a functional deficit zone. The epileptogenic lesion that is evident on the MRI, there's an extensive left frontal and insular lesions. Eloquent cortex of the Broca is just anterior to the lesion. In the symptomatic zone, it looks like a left frontal semiology, Bonini 1. And we think the epileptogenic zone might be the left frontal. And our question to the faculty is whether we should go for SEEG to delineate the epileptogenic zone and map speech versus directly going for ECOG surgery with intraoperative mapping. And if so, where and how wide should we sample and resect? Dr. Danish?
Thank you very much. Wonderful presentation. Thank you.
Thank you, sir.
And thank you so much for the kind introduction. Yeah, I think this is a very, I mean, it's actually quite straightforward, but at the same time, because of the problems that you have rightly alluded to, no, it's very close to the language area. And the gliosis is quite extensive. And the anterior margin of the gliosis is just abutting the pars triangularis, if you look at it, the inferior frontal gyrus. So that there's absolutely no doubt about it. So and then it also involves the insula. So the seizure type, let us examine the seizure type. The seizure type is basically, as you rightly put, it's elementary motor. But before the elementary motor, he gets some kind of a symptom which he is not able to describe. Now, whether that symptom is I don't think he's not able to describe. So we are not sure whether it's some kind of a sensory symptom in his on his face, or something happening in his mouth. But anyway, he's not kind of choking, or he's not in any kind of distress as such. So that is there, but he's not able to describe beyond that. So, and then it is followed by this perioral kind of thing, as well as he has a lot of saliva that is coming out. So there's absolutely no doubt that it's a lower Rolandic that is involved. The symptomatogenic zone is clearly lower Rolandic, and the insula, because and then you have the lesion, which is exactly in relation to that. So everything can actually be explained by that the lesion. So there's a concordance between the lesion as well as the symptomatogenic zone. That much is very clear. What is not clear is, what is the aura? So we don't know what the aura is, but let us leave that aside. Now, there are two things to this history. I want you to clarify what is the seizure frequency right now?
Initially, he was getting a seizure every week. Then we put him on carbamazepine, and now he's controlled for almost 1.5 months.
He's
No
not had a
seizures.
single. He's not had a
No,
single
no.
seizure.
Oh, since we put him on carbamazepine.
Yes.
That was 1.5 months ago.
Yeah, correct. So in a fairly good dose. Oh,
Yes. Yes.
okay. And he's never had. Now this this MRI was taken only after the seizure onset, isn't it? I mean, just
Yes.
about 6 months ago, correct?
Correct.
Because he's now 10 and he began at the age of 9.5.
Yes. He never did an
And
MRI before.
but he's never had an MRI, and there was no reason to do that. But at the age of 7, he had some febrile.
Yes.
What was that? That was a seizure, or
No,
it was
no,
only
no
a fever?
seizures. Just
It was
a
only just a
fever,
fever.
prolonged fever.
Prolonged
Yeah.
fever. Okay. So, and he never had any perinatal kind of an insult.
No.
Nothing at all
Nothing
to
at all.
account for. Yes. So there's no real reason why that gliosis has happened. We're not able to
Yes.
exactly tell at what point the gliosis actually took place, right?
Yes, correct.
Yeah. So now, you very nicely also mentioned that, is this also a kind of, at the same age, you may have a lesion there, but at the same age, you may also have, it overlaps with the self-limiting benign epilepsy syndrome,
Mm-hmm.
and many times we have seen, with static encephalopathy like cerebral palsy, or just like that, they have a static encephalopathy. They may have bilateral lesions or unilateral lesion or whatever it is, but they are growing up. But there's a delay in development, but they are catching up. And at the age of about 6 or 7, they start having this kind of perirolantic kind of a seizures. And by the age of 10 or 11 or 12, they start disappearing. The self-limiting epilepsy can come in a otherwise normal child, or even a child with an abnormality. Now, you do not know at what stage this abnormality has taken place, whether this abnormality looks a little old, quite old. Doesn't look very recent at all. I never had
Yes.
anything dramatic at the age of, say, 6 months ago. Nothing. There was
No, sir.
no insult, or there's no real insult about 6 months back at the onset of a seizure, right?
Yes, correct. Never.
There wasn't.
No. And
Neither
because
trauma, nor a vascular insult, nor a encephalitic illness, nothing.
nothing. And we
Absolutely
were
nothing.
thinking he's Rolandi because of the EEG. It's also showing bilateral independent temporal spikes.
Exactly. Now, we'll come back to that. Now, we do not know the age of this lesion. That's the number one.
Yes.
Number two, you mentioned that there was nothing hyperacute in this onset of his seizures. It was not a correct, right?
No.
Yeah, no. So that is the second point. The third point is, over the last 6 months that you have been following him up, he's not in any kind of an encephalopathy, right?
No, his
You said
development
that
is
he's
still
performing. You said he's
still performing
performing
very well.
very well.
Yes.
And number 4, you have shown that with the appropriate medication, he is now seizure free, right?
Correct.
And does he require high doses?
He's actually on 30 milligrams per kg per day of carbamazepine.
Okay. And does he exhibit any side effects?
No, he's tolerating it well.
Very well. And he's seizure free. This is my approach in this particular boy. His epilepsy is very short in its duration, right?
Yes.
That's the first point. The second
Yes.
point is, it doesn't matter how short it is or long, that doesn't matter. But more important is that he's cognitively completely intact.
Yes.
And his epilepsy has not affected his cognition or his scholastic performance or whatever it is, right?
Yes.
And he at the moment he's well controlled with one medicine, right? So so these are the good points that he has. Now, if you look at his EEG itself, his EEG ontogeny is good, right? And he's got, these spikes which are kind of monomorphic kind of spikes with the same centrotemporal distribution, which we normally expect with a, self-limiting, so-called benign or self-limiting focal benign childhood localization related epilepsy. So and then his sleep markers are normal. So with all these points, and it's bilaterally distributed, of course, even in a lesional case, you can get bilateral, so that doesn't really matter. But overall, if you see, short history, well controlled, normal boy, in an age where you have the self-limiting epilepsy coinciding with whatever the lesion is there or not. So all these points, what I would do in this particular boy is I would just follow him up, study his natural history better over a longer period of time, see whether it kind of on its own come down, because he's at the age of 10. And if you look at the self-limiting focal epilepsy of that, the centrotemporal type, they generally kind of start coming down over, by the time they are 12 or 13, it kind of goes off.
Yes.
So I would spend time just studying his natural history. However, when I'm studying his natural history, in case this boy starts getting more and more focal seizures, requiring, not responding to this drug, which is carbamazepine, I wouldn't waste my time then after that to, try another medicine, then I would shift gears. Right now, I would just observe this boy. The reason why I would observe this boy is for this particular thing, that this could be very well be a selects, which is overlapping on a lesion whose age we do not know. The age of the lesion we do not know. It looks very chronic, and it looks quite settled there. It's not something which has happened, and you do not have a cause, a recent insult that has resulted in this lesion. You don't have that kind of a history, right?
Yes.
So it looks quite dated. We do not know at the age of 7 whether, that prolonged fever, whether it's a mild focal encephalitis, we don't know. That much is possible. So I would, my approach would be, I would wait to study its natural history. Just because of that last history that you gave, that he's responded well to carbamazepine, and he is cognitively completely intact. You said that he's quite high functioning.
Yes.
He's a bright boy, you said.
He is a bright boy, yes.
He is a bright boy. I wouldn't like to, whether you implant him or not, if you decide to operate, you would have to go to that gyrus, to that gliotic region, and then you would have to remove that area. You would have to definitely remove that anterior boundary there, which is very close to the pars triangularis. You would have to completely resect that. You would have to resect the anterior part of the insula. You have to do it completely resected. So that is the surgical strategy is fairly straightforward. You can't afford to keep anything there. You would have to do it. And in doing so, you would, of course, spare the pars triangularis, and then you would resect it. Regardless of whether you do stereo EEG or not, you would have to do that. You would have to do that. You can't spare any of that gliotic area, because that, even if, and now you spare it at a later point, you would have to operate on it again. So these kind of lesions are, in our experience, gliosis in that region, if you leave behind some tissue, it's going to come back to you. It's going to bite back. So you would have to resect the whole thing close to the pars triangularis, but not involving the pars triangularis. So it is a one-stage procedure, in my opinion. I would love to hear my colleagues whether they have an alternate opinion. But the first thing is, I would just wait. That's my approach. Sorry for taking a long time, but this
No,
is my
thank you, sir.
approach. Yeah, I would love to hear my colleagues. Thank you.
Thank you, sir.
Yeah, yes, sir. Actually, what about the neuropsychology evaluation? Even though he is brilliant, we have to do the neuropsychology evaluation, like his IQ and which domains is good and which domains is lacking.
We only
And
did
what
IQ,
about any?
but I don't have it with me now. But maybe I'll bring it and show it to you next time. But I think it was around 105 or something like that. So
Okay. Then any soft neurological signs like clumsiness of the right hand or any facial asymmetry,
no,
hemiotropy.
no.
Okay. Yeah. Then with this short history and response to drug, so we have to wait and watch only, like Dinesh sir said. So there is no indication as of now.
Okay. So when we first saw this patient, we were thinking of Rolandic because of the EEG and because of the seizure semiology. But then the MRI came up like this, and then we were able to record so much seizures, and so it is the patient himself was actually seeking surgery. So we were firstly asking whether this patient is a surgical or a Rolandic patient with an incidental lesion. And then whether, if ever we will operate on this patient, will it be a one stage, or will we have to implant SEEG based on this, the extent of this lesion and the proximity to the Broca's? That was our question. So, as Dr.
That is the
said,
thing. Like we have to follow up. We have to document what is the present semiology, and we have to see how it evolves in future. So depending on that only. Now we are recorded actually. Sometimes the RA might come up in the future. Now he is not able to describe it. Future some other symptoms can add up. So those kind of things will give clue, and whether it's a benign Rolandic epilepsy or it's a symptomatic epilepsy, and other things like following up is developing encephalopathy, drug refractory. Those things also will give the indication, and depending upon that only we can go for it. And the area we know, dominant hemisphere, and we have seen many patients with lots of more gliosis than this, and remaining seizure without any seizures. Very big gliosis and without any seizures. So with this, we can't conclude now. So we have to obviously wait for the natural course of the disease.
thank you. Okay.
Of course, this is a fascinating discussion. Thank you for your.
I'd like to ask a question, Dr. Ahmed. First of all, thank you very much for the very nice case.
Thank you very much.
Actually, when we are faced with, usually when we are facing central temporal spikes like that case, and the child is pretty brilliant and he is normally going and controlled by the medication. What makes you do the MRI? Usually we give the medication and we don't do more extensive
Yes.
investigations.
Actually, we didn't do the MRI. The patient came with the MRI. This was the problem. He came with the MRI with the lesion, and he came for asking for surgery, and then we did the workup, and then we saw that it looks so much like a Rolandic case. So this is when it was confusing to us.
So if he's not coming with MRI, would you like
We wouldn't have asked for an MRI.
You wouldn't, because
we would have waited until because it looks so much like a Rolandic epilepsy because of the EEG and the seizure semiology and.
But usually the Rolandic is coming by night, and this case is coming. The attacks is coming during the daytime as well, which is not that.
And this was we recorded 3 seizures actually in the EMU, so we never actually captured a Rolandic seizure before, so. The possibility of capturing a seizure from a Rolandic case is also
very rare.
Yes, exactly.
Very, very rare. Yeah, I have it. I have just once. I have recorded just once in the whole of my life. Anyhow, I appreciate the comment of the dear professors. And yes, it's not uncommon to have benign focal epilepsy cases with lesional, old lesional cases. Thank you very much for the case.
Thank
It's
you,
wonderful.
Dr. Anna.
Thank you.
Thank you so much. Thank you so
Thank
much.
you. Wonderful discussion. And I think it's very, very important. A lesion is there. That lesion can actually explain his seizures. But because the child is well preserved and cognitively normal, and as you rightly put, if the patient had not come with an MRI and looking at that history, you would not have asked for an MRI straight away. That itself tells that you are thinking more of a benign.
Yes.
So in such a situation, I think it's always prudent to wait, and at any time we can always get him inside. It's not a problem at all, because that also gives you the opportunity to study his natural history. The reason why we are telling that is, at this age, and you have already shown that, on your nicely done functional fMRI of the language, you've done the language fMRI, and that is showing it's there. It's on. Obviously, it has not shifted to the other side. You don't expect it to shift, because
Yes.
if any shift had taken place, it would have taken place long back. That's number one. Now, that also tells you a little bit about there are two ways of interpreting this non-shifting of the fMRI. One is that the lesion is rather recent. Now, if the lesion was very old, I mean, very early in life, maybe the language would have shifted. That's the one way of looking at it. But the second point is, the lesion is not exactly on the pars triangularis. So remember that. So it is just a little more posterior to that.
Yes.
So yeah, so that way there was no reason for the for the language to shift to the other side, even if the lesion was old. So these are the subtle ways of dealing with this. Now, you would have, supposing you operate on this boy now, whatever you do, whether you do it with stereo or not, that could be, when you're going and resecting that area, that you could have some language deficit for some time, at least temporarily. That's for sure. Would you like to do that for the child who's now seizure free on medicine, one medicine alone? And you think that this is probably a self-limiting. It could be a self-limiting. You never know. So why do we have to take that chance now? That is my second reason or argument why I won't do a surgery now.
I think Dr. Shaimaa would like to ask a question. Go ahead, please, Dr. Shaimaa.
Thank you, Dr. Ayn. Thank you, Dr. Ahmed, for this nice, very nice discussion. Because sometimes we even see patients with genetic generalized epilepsy and they have MRI brain lesions. So, to ourselves, the lesion guilty. Can the lesion explain the seizure physiology and the epilepsy syndrome the patient is having? But in this particular case, it's a great coincidence between the physiology, the MRI, and even the EEG. The fact that the area is affected in the MRI together with the ganglia can truly explain the fingerprints of the ictal discharge. But this is also bringing us to the first very question. Is it really a Rolandic or it's a pseudo-Rolandic seizure? And what are the soft signs that can differentiate both? Because pediatric patients, sometimes we can go for epilepsy surgery even if the patient is controlled with a single medication in the presence of a lesion away from the locant area. The problem here is that the lesion is very close to the focus area, as you just beautifully explained. and that the patient is really controlled on medication. But as we all know, sometimes patients with drug resistance have some remitting relapsing courses like in MS. They have periods of honeymoon response to anti-seizure medications, and then they can relapse again. So my question here, how to differentiate between that this light appearing Rolandic as if it's Rolandic epilepsy, but it's not truly Rolandic. It's some sort of lesion epilepsy. And could this patient be ever weaned off anti-seizure medications, even for 5 years or even longer?
Thank you very much. I think your voice was a little, in the sense that I think it was fluctuating, but I think the essence of what you were asking is that very correctly. This is the thing. You see a lesion, and that lesion can explain the seizure type, and so therefore, why not operate? Correct. Now, supposing this lesion was in a non-eloquent area, and if the patient says, I don't want to be on medication, I would like to get out of it and all that. Yeah, you could probably operate straight away. But this is, close to an eloquent area. You know that you will disturb it a little bit, at least temporarily for some time. There could potentially be a language deficit for some time, and then become all right. Would you like to take the chance now? Or would you like to study that natural history? See, the point is, lesions, as Dr. Arun was just mentioning, lesions behave differently in different people. Just because there's a lesion, it does not necessarily be epileptogenic in a given patient. I would assume in this case, I would have two hypotheses here. One, this lesion is silent and the boy currently is having a selects. The second hypothesis is that, yes, this is a lesion and this is producing his epilepsy. So these are the two. How do I distinguish between these two? Well, I would just follow this patient up. And I would see, because if this lesion is indeed causing his epilepsies, it's likely very quickly it's going to become drug resistant. It's not going to, respond.
Yes.
So we'll wait and see. 6 months is too short, I would say. And especially when the last 1.5 months, he's not had a seizure. And more importantly, he is cognitively intact. He's not, his medication is not producing any problem for him. And he's doing well. So I would wait. These are the reasons why I'll wait. But I'll keep both the possibilities. One is that the lesion is silent and he's got a benign or a selects. The other one is that lesion is truly producing epilepsy, but at the moment it is drug sensitive. These are the ways in which I do. So I'll just follow.
Dr. Danesh, I would like to ask a question. If you delineated the two possibilities very well. The first possibility is a silent lesion within a select syndrome, and the second possibility is the patient it's drug responsive. Okay, so but we wouldn't expect for it to be that won't last long, right?
Yes, it could be. Yes.
Yeah. So then, according to the lesion that you are seeing, what do you think of the role of SEEG versus proceeding directly to surgery?
Very good question. In the early part of our epilepsy surgery development, we used to just to delineate the epileptogenic zone from the functional zones. We would implant, and then we would map out the functional areas and then the epileptogenic zones. But what we have seen now is even with that, you would definitely have to resect that the lesion. That there's no doubt, whatever be the thing. So here, in that case, whether you do stereo EEG or not, you have to do a full surgery. Full surgery, what I mean is that the entire gliosis has to be resected. And here you can spare as long as you. The other thing that we have also realized is as long as you do not disrupt the white matter, the arcuate fasciculus that connects the pars triangularis to the posterior temporal region, the vernix area. Even if you resect part of the pars triangular, nothing is going to happen. They would have a temporary language deficit for some time. You would have to warn them that, you'll have some slightly non-fluent speech for a few weeks, and then you'll recover. As long as the white matter is intact. Now, that is a surgical skill. I mean, that's where the surgeons come mostly into the. I mean, that's entirely the surgeons' this thing, where you should not violate the white matter. And if you resect only the gliosis, sparing the white matter of the deep white matter, I'm sure you will be able to do without stereo EEG. You can resect the entire lesion in that location without the need. It's a one stage procedure is what I would do.
Yes, thank you so much.
Yeah.
We have a question from the audience. Dr. Nagowi, I hope I'm pronouncing this correctly. Please go ahead.
Dr. Nagy.
Hi, everybody. Yes, Nagy. How are you?
Sorry.
Yeah, so I'm a consultant radiologist. I just have a quick observation I wanted to share. I think on the function MRI, if you can get the image, I think it looks rather on the exner's area, which is, here. It's located just posterior to the Broca's. So, and this Broca's looks like the dominant one. So I think if you are going to have surgery on him now or later on, you may have a risk of him developing agraphia or like problems in writing. So I think you can just put that into consideration. We can maybe try to do a fMRI for it. It's going to be a bit difficult, but I just wanted to share this observation for you because it looks posterior to pars triangularis. So even if you don't hit the pars triangularis, I think the exner's area is at risk in this patient.
It's a good point. Very good point. Very, very good point. Very pertinent. And any surgery in that area, there would be some deficit. Fortunately, unlike an ischemic lesion where the deficit lasts quite long, these surgically induced deficits, unless you have removed the entire thing and you cut the white matter, most of them will recover in anywhere between 4 weeks to about 12 weeks, even if you have produced a deficit. That is our experience. So, yes, you're right, absolutely right. I mean, you're very close to or at the eloquent cortex. There's no escaping that. That is all the more reason, as you rightly put, there's all the more reason why you should study this boy's natural history. Because it could just go into remission. We never know. The lesion may just remain there, may produce an occasional episode sometime. Unless this boy really gets into a drug resistance, I wouldn't do anything now. Definitely not now. At a later point, definitely yes.
Okay, this has been a fantastic discussion. So to summarize case one, do you have someone from the audience that have a question before we summarize?
No more questions. Okay.
Yeah. So to summarize case one, we have a pediatric post-encephalitic case, which was close to the motor and language area, but the patient semiology and the temporal relation between the correlation between the lesion and the patient's response to medications and the EEG and the development of the patient and makes it like the first possibility would be that it's a silent lesion with a self-limited epilepsy syndrome, and to follow up the natural history of the patient. That is what seems to be the consensus from our panel, and so we will move now to our next case. Dr. Shaimaa Shaban is an assistant professor of neurology at Cairo University, and she's one of the most thoughtful, kind, and brilliant neurologists I've ever had the privilege to shadow and learn from. Her case this time, we're dealing with a post-traumatic epilepsy. But the problem is bilateral. We have encephalomalacia involving left superior frontal, orbitofrontal, temporal pole, but also there's a lesion on the right side. And once again, the fMRI shows Broca's area in close proximity. So the question, what we should be looking for is with multifocal and bilateral trauma, how do you determine the primary driver of the seizures? And can SEEG help untangle this? Or we are looking at a palliative approach from the start. Okay, Dr. Shaima, please take us through this case.
Thank you, Dr. Thank you all. It will be my pleasure to present this case and have your insights here. But may you please allow me to share my slides?
Dr. Shaima, will you please try to change or adjust the microphone, because the voice is usually interrupted. We can't listen well, can't hear well.
Is that clear now?
I think it's the same.
I'm trying to change the network. Just a moment, please. Well, I'm trying to change the network, but I can't share my slides. May you please enable sharing? May the host please enable sharing?
You can just share you just press
everyone can share. Yeah, you can share. Just press the share button and select your screen or window.
Okay.
Are you using your laptop or your phone for the voice?
My laptop.
Can you log in with your phone and use it as a speaker? As a mic?
Okay, I will try.
Dr. Ahmed, can we take 5 minutes rest in between to pray, because
Yes, okay. Yeah,
it's better. Till her adjustment, we can have 5 minutes.
Okay. Yes, okay.
Yeah, of course. So we'll be back at 6:10. Okay.
Ahmed, meanwhile, can you give update about the last case? I mean, last week's discussion. Those two patients whom we had decided about doing recording of EEG. Can you give update on those two patients?
Yeah, Dr. Ahmed. Yeah.
Yes. So basically, we discussed two patients last week. The first was Nada, the patient who had two lesions, one on the right temporal and on the right occipital lesions, with seizures coming from semiology and ictal onset coming from the left side. And we have recorded 5 seizures, but the patient was reporting some aura, and Dr. Danish was asking us to record seizures again to make sure that we capture the seizures with aura, and that the seizure with aura is electroclinically similar to the seizures we captured. And we captured 2 other seizures, unfortunately, again without aura. But we sat with the parents and the patient, and we showed them all the video EEGs we recorded, and they are positive that this is the only seizure type. So we will again try to record the aura, and we asked her whether she always has aura, and she said no, that sometimes she gets aura and sometimes she doesn't. So that was regarding Nada. And for Lara, I think Dr. Danish, he asked to see the actual MRI, which I think we will be able to do next week, because we don't have the MRI currently with us. And I'll share it with you also on WhatsApp.
Ahmad, what about you? You are not going for prayer?
Yes, we will just be there for 5 minutes, okay? We'll break for 5 minutes.
Yeah.
Okay. Thank you.
Okay.
Hello.
Hello, Dr. Mohammed. We're just on a 10-minute prayer break. Just waiting for people to join back.
Can you see my screen?
Yeah, it's clear.
Okay, so I'll share, and Dr. Shaima hopefully will be able to talk.
Perfect.
I think we can start. Dr.
Dr. Shaima, are you here with us?
Can you hear me?
Yes.
Yeah, we can hear you perfectly. Yes.
Yes,
You can
this
begin.
is much better.
So sorry for these technical problems. Let's jump to the second patient. He is a male patient, 30 years old. He's right-handed and he's a low college graduate with frequent work leaves due to his current seizures. He's a product of a negative consanguinity with irrelevant family history and unremarkable perinatal history, and his development is age-related. His seizures, regarding his seizure history, regarding his examination, his general examination is completely normal, and so is his neurological examination, including visual field by confrontation. However, after reviewing the patient data and the investigations, we requested a perimetry for the patient, which revealed a right bilateral inferior quadrantenopia, which the patient is not aware of. So this was proven by perimetry, as you can see, but the patient is not aware by this field defect, and even it's not evident by confrontation test. So the next slide, please. His epilepsy history, regarding his epilepsy history, his seizures started 6 years ago as an immediate post-traumatic seizures. The patient experienced a road traffic accident, which was associated with left frontal subdural hemorrhage. This was evacuated, and the patient was admitted to ICU, intubated and mechanically ventilated. His conscious level pre-operative was almost, the Glasgow coma was almost 9 was almost 9, and post-operatively the patient was fully conscious without a motoric deficit. Can you shift to the second slide, please? Next slide, please. This is his post-dural hematoma evacuation. Can you please shift? Showing the left frontal subdural rim, and this is the photo of the patient in the post-operative period. Can you please shift to the next one?
Yes, I did.
Well, his seizure, his current seizure type is characterized by right focal motor impaired consciousness seizures, which sometimes evolve to bilateral tonic.
Dr. Shaima, the sound is not the best. Can you repeat the last few sentences, please?
Okay.
Dr. Shaima? Once They occur out of per month, although it's
Dr. Shaimaa,
can you hear me?
Yeah, can you repeat the seizure semiology? Start from the seizure semiology, please.
Well, his seizure types, he's having a single seizure type characterized by right focal motor impaired consciousness semiology, which sometimes evolve to bilateral tonic-clonic. These occur mainly out of wakefulness with a frequency of twice per month. Sometimes the patient is having a clustering of seizures with status epilepticus, and this was associated with multiple traumas, including bilateral shoulder dislocation, necessitating surgery. He tried multiple anti-seizure medications, and currently he's on maximum doses of levetiracetam and lacosamide. And previously, he tried other sodium channel blockers, which he developed adverse events from them. Can you please move to the video of the seizure semiology? Well, the seizure type is characterized by the following. Sometimes the patient is experiencing some auras of dysphagia. This was described by his relatives as preservation. He keeps to repeat the last word he just said, and sometimes this is associated with word finding difficulty. In the past, he used to have vertigo, even before dysphagia, but this is not occurring right now. Then the patient have this staring look, synchronous head and eye deviation to the right, tonic with superimposed clonic facial deviation to the right, asymmetric tonic posture of both upper limbs with right upper limb lead, which evolves to figure 4, with the right upper limb being extended and the left upper limb being flexed, and then the patient evolves to bilateral tonic-clonic. As we can see, during the phase of the evolution to bilateral tonic-clonic, his hands were fisted with pointed index and sometimes with right pincer pointing. At the seizure end, you can appreciate the asymmetric clonic ending on the left upper limb and perioral region. And post-ictally, he's having agitation, sometimes with right TOTS paralysis, and also sometimes with dysphagia. So what is consistent across all his semiology is the staring look within the motoric evolution. The aura and the post-ictal manifestations are not consistent across the seizures, and they had a little bit difference from the very beginning of the seizure 6 years ago till currently, where the vertigo was very prominent initially, and currently it's not as frequent as previously. So can you shift, please? This is a second video for his seizure semiology, and it's almost the same. The patient is having
It's not playing.
this staring. So I will have some discussion through these questions, and you can answer in the chat section. I said that the patient was previously experiencing vertigo as an aura. Do you think that where do you think vertigo could be generated from? Lateral temporal region, superior parietal lobule, inferior parietal lobule, posterior insula, or all of the above? Any of the above. You can answer in the chat section, please. So Dr. Danish and Dr. Aaron can discuss where they think vertigo could be generated from, because I think we need to understand the semiology of the patient before formulating a hypothesis where the seizures are arising from. So the floor is yours.
Yes. So vertiginous aura comes from generally from the parietal lobe, especially the inferior parietal lobule. That's the region which actually generates this particular kind of a symptom. That generally actually, this vertiginous aura, is it really a true vertigo, or does he just says that I just feel some lightheadedness or giddiness? Because um, a true vertiginous aura generally comes from the parietal lobe. It could come from the posterior insula also, but maximum it comes from the parietal, especially the inferior parietal lobule. If you they've mapped it out very nicely on functional stimulation and all that, basically to the inferior parietal lobule. And we have also, during stereo EG, we have when we stimulate, when we have these electrodes there, when you stimulate some of these patients, not all, some of these patients have said that, yeah, I now feel vertiginous sensation. We have recorded that both from the posterior insula and from the inferior parietal lobule. Much less, at least I have not seen it from the lateral temporal, sorry, or superior parietal lobule. Generally, no, but inferior parietal lobule, yes, that would be the region. What do you think?
Yeah, I totally agree with
Yeah,
you.
this
Yeah,
yeah,
please.
this
go
it
ahead.
can arise from any of the above, and also like Sir said, it's most common in the parietal lobe and also in the lateral temporal. In some of the studies papers, they reported more, around 50%, mostly in the posterior temporal region, T4 region and all, followed by parietal, and less frequently in frontal and occipital also. But like this order only, like it's some posterior temporal region, that is more common, but it's temporal only, not occipital. So followed by and frontal, and then occipital at the last. So it can arise from any of the area.
Sorry.
Yeah, Dr. Shaima, you may continue.
Yes, please. My next question would be about ictal or post-ictal aphasia. Is it a true lateralizing to language dominant hemisphere, localizing to periselvian speech centers, or it's either non-localizing nor lateralizing? Please write down your answers in the chat section. Okay. Okay. So regarding dysphasia, they are truly lateralizing to the language dominant hemisphere rather than being localizing to the periselvian speech centers. But it's not just dysphasia as it is. It's the pattern of dysphasia which differs from frontal lobe epilepsy to temporal lobe epilepsy. And we need to have a small hint about the difference between the aphasia and the speech arrest, like in the previous patient with these opercular seizures. So again, the floor is yours, Dr. Aaron and Dr. Danish.
Yeah.
Yes, please, Dr. Danish. Go ahead.
Yeah, I mean, it's clearly it just post-ictal aphasia is a very significant. It lateralizes to the dominant hemisphere basically, and then so that's very clear. There's absolutely no doubt about it. It's a very strong indicator, but the important thing is that the post-ictal dysphasia usually, there is a definition saying that the post-ictal aphasia should last for about 2 minutes post-ictally. I mean, it's difficult to time it like that, but nevertheless, whatever it is, post-ictal dysphasia is very significant. And one has to be careful about the definition, the distinction between postictal aphasia and postictal confusion. So that's an important point that we have to. In postictal dysphasia, the person is not confused. The person is aware, understands, but not able to speak. So that is what is a postictal dysphasia, generally speaking. So that's something that we have to be saying. Yes. Anything else?
Dr. Ara?
So we are discussing the aura here. Is aura is like a perseveration or a word finding difficulty, right? Hello, I'm asking about this case actually regarding the aura.
Your voice is not very clear, Dr. Aron. Can you please say the question again?
Okay. Now can you hear? Like I asked
Yes.
aura of patient. The aura of the patient is mainly word finding difficulty and perseveration, right?
Yes, he's keeping repeating the last word that he was saying, and sometimes he has word finding difficulty. So it's repetition.
Okay.
There's
Yeah, there's
repetition.
post-exposure dysphagia. It's mostly it's dominant, and yeah, that can happen even after secondary generalization also. So we can't quite always rely on it. So mostly, most of the time, always not 100%. Most of the time, it's dominant and it's a significant thing. But we have to so only we should not consider about the end of the seizure. Mostly the aura, or that also gives us more clue about where are the places. Like previously also you said now, like a vertiginous aura. Vertiginous aura also comes from parietal lobe, and this word finding difficulty, it can arise from any of the area. Like perseveration means it can arise from the dorsolateral prefrontal cortex. Then word finding difficulty can arise from Broca's area due to motor aphasia, and Wernicke's area also it can arise, and also in the parietal lobe. Parietal lobe explains the previous vertiginous as well as the current word finding difficulty also. So like that, we have to analyze everything.
Yeah. Thank you. Can you please continue to the next? The post-ictal thoughts paralysis is a lateralizing phenomena to the contralateral hemisphere, localizing phenomena to primary motor centers. Please answer in the chat section. So post-ictal thoughts paralysis is more lateralizing phenomena to the contralateral hemisphere than localizing to the primary motor centers. May you please shift to the next one? Regarding the post-ictal psychosis, the patient is experiencing post-ictal aggression and behavioral changes. So this aggression is non-localizing, non-neutralizing, more common in temporal lobe epilepsy than in frontal lobe epilepsy, more common after prolonged and bilateral tonic-clonic seizures, or all of the above. It could be any of the above. Yeah, correct. It could be any of the above. May you please shift to the next one? Which version sequence is incorrect? We are talking here about the sequence of version, which is the eye deviation to a side. When the eye moves before the head, this points to occipital seizure generator. When the head and the eye moves together, this points to frontal eye field seizure generator. When the head moves before the eye, This indicates parietal lobe seizure generator. Hemifacial involvement usually occurs in association with eye and head version due to close proximity of the frontal eye field to the frontal operculum. Remember, you should choose the incorrect sentence. May you please write your answer in the chat section. Perfect. When the eye moves before the head, this usually points to occipital lobe seizure generator. When both moves together, like in this one, this indicates that the frontal eye field has been involved. And due to the close proximity of the frontal eye field to the frontal operculum, usually hemifacial seizure then ensues. Usually it's tonic, but sometimes with clonic, superimposed clonic activity, like in this, in our patient. The head before eye sometimes points to temporal lobe seizure generator, but this is not always a solid association. Can you move to the next one, please? Which hand posture are more commonly encountered in frontal lobe epilepsy? The index pointing and fisting, the politician fist, the index pointing, pincer and the cupping. Please choose the more common hand posture you are more frequently encountering in frontal lobe epilepsy. For me, I always remember that the index pointing and fisting are very primitive. So they are more likely to be arise from the frontal lobe generator rather than from the temporal one. They are one of the very primitive encountered hand posture, even in the development of children, as we can, that is very nicely illustrated in this beautiful study. So the fisting and the pincer and the pointing are both likely to point to frontal lobe seizure origin, and the cup, politician fist, and pincer are more likely to point to the temporal lobe seizure origin. Can you please move to the next slide? So let's map the seizure network from what we have just discussed. The patient is describing an aura of dysphagia as he, according to his own words, as preservation and word finding difficulty. Sometimes this was associated with vertigo in the past. This might the dysphagia might point to language dominant hemisphere. The vertigo, as we just said, it could point to parietal, temporal, or even insular generator. The staring look followed by synchronous head and eye version to the right points to contralateral frontal eye field involvement, which is the left frontal eye field here. The tonic facial deviation to the right points to involvement of left frontal operculum. The asymmetric tonic posturing of both upper limbs with the right upper consistent right upper limb lead points to left hemispherical involvement. And with this very nice figure of 4 with the extended right upper limb, this points to the left hemisphere, especially the left SMA or pre-SMA, and the hands being vested with pointed index. This points again to frontal lobe, but sometimes the patient is showing this pincer posture, so the temporal lobe is also might be affected, but this is during the course, during the journey of spread of the epileptic discharge. At the end of the seizure, the asymmetric clonic ending on the left upper limb points to ipsilateral hemispherical involvement, and with the post-ictal right thoughts paralysis, this again points to left hemispherical origin of seizure. Can you please just press the button, Dr. Ahmed?
I did.
Yes, please again. This is the sequence of seizure, or the my mapping to the seizure spread hypothesis, and this is open to discussion from our esteemed panel.
Yeah. You actually very nicely described the whole extremely well. So it's quite clear that this is a very clearly lateralized seizure. It is from the left hemisphere without a doubt. And the symptomatogenic zone is more frontal. But the onset or the origin may be a little away from that. You know, just because of the two facts. One is that he had this vertiginous aura. That's the first thing. That vertiginous aura could be parietal, could be post-insular, could be lateral temporal, posterior temporal. That's where usually the temporoparietal junction, that area. And so that is, so it could mean that the seizure may begin there and then go more anteriorly and manifest entirely as frontal. The rest of the seizure is actually frontal because he's got the head and eye going to the right, and then that asymmetric tonic posturing, ATLP, and then he's bilateral tonic clonic, and then finally he has a postictal tod. So everything is frontal, but the origin seems to be behind the frontal, and from there it is going into the frontal. Behind and probably below the frontal. So you have to be very, very careful with that. That's the reason why we have to analyze place a lot of importance on the first symptom that the patient experiences, which is the aura. And so that gives a clue. And the second thing that tells you that that it could be the parietal is because he has an right inferior quadrantic field defect. Right inferior temporal quadrantic field defect. That tells you that it is the parietal lobe and not the temporal lobe. That is a very strong indicator that the parietal is more involved. If you then there's a concordance between that and the vertiginous symptom, and the parietal lobe is richly connected to the frontal. And so, therefore, you get that spread anteriorly and manifest as frontal. So that is the region of interest for us in this case. Yes. So even if there is a lesion, that you said that this is a post-traumatic epilepsy, very important. In post-traumatic, you are likely to see multiple lesions, multiple regions, either on one hemisphere or both hemispheres. And even with these multiple lesions, at the moment, the one that is operational in him, the epileptogenic network that is operational in this gentleman seems to be the parieto-frontal or the temporoparieto-frontal network on the left side. That is what it is. Yes.
So can we move? Do you have any comment, Professor Aaron?
Yeah, that's the thing. What about the PET scan? Sir has nicely explained.
We haven't yet reached the MRI as yet. I think we are now
So
going into the...
Definitely. So we have to...
Let us... Yeah,
okay, sir. I thought it's there.
Okay, so this is this interictal EEG with the posterior dominant rhythm being in alpha frequency, bilateral, symmetrical, and reactive. And the interictally, he was having these left frontotemporal sharp waves, which sometimes occur in runs and acquiring a periodic or quasi-periodic pattern. May you please jump to the next slide, Dr. Ahmed? As we can see here, he's having left F7, T3, lateralized periodic or quasi-periodic discharge, and this was almost continuous all through the recording. We recorded for him almost 24 hours, but on three separate attempts, and we recorded four seizures. And as we can see, the left anterior temporal lateralized periodic discharge was always there. So coming to his ictal EEG. As you can see, this is a referential montage. The patient is awake. And then you can appreciate the appearance of rhythmic theta with superimposed fast activity in the left temporal derivations in F7, T3, and then it involved T5. These occur much earlier, even before the very first clinical phenomena to be encountered. These occur around 30 to 40 seconds before the first clinical phenomena. As we can see, it's on the left temporal derivations. And then the patient will have his habitual seizure, but without the aura. The attempt to record the seizures was made possible by the reduction of his usual doses of anti-seizure medications to half, and that might explain the absence of aura in the 4 recorded seizures. You can see the evolution of the electrical onset of the seizure. And then it's coming here. The patient developed this stirring look with simultaneous version of the head and the eye to the right. With tonic facial deviation with superimposed clonia. And then he had this right upper limb tonic elevation. And then he evolved to the figure of 4 with the extended right upper limb and flexed one. And then, as you can see, he is having the right pincer hand posture, the left pincer and the right fisting. And then he evolved to bilateral tonic-clonic. Here the EEG is masked by a muscle artifact. At the very end of the seizure, the patient is still experiencing the right upper limb and perioral clonia being as asymmetric endings. And that's all. The second seizure is almost the same.
Stop playing.
And this is another seizure, but it's almost the same. And this is his the electrical onset of the seizure in the left temporal derivations. Can you please move to the next one? So after reviewing the EEG, how would you describe this epilepsy in terms of localization? Is it a mesial temporal lobe epilepsy, a lateral neocortical temporal lobe epilepsy, a temporal lobe plus epilepsy, or it's an extratemporal lobe epilepsy? You can answer in the chat section. Well, if it's a temporal loop plus epilepsy or it's an extratemporal loop epilepsy, this is where we are standing now, and we want to hear more from our esteemed panel. We can jump to the MRI directly, please. Well, the patient performed 1.5 Tesla MRI in epilepsy protocol, epilepsy hardness protocol, and as expected in post-traumatic cases, the patient is having a very widespread left hemispherical involvement, and you can appreciate the presence of all these encephalomalacia in different locations within the left hemisphere, including most of the left frontal loop, also a small area in the left temporal bole, precuneus and cuneus, and also a small gliotic area in the right temporal bole. The left superior frontal gyrus, orbitofrontal and frontal pole and middle frontal gyrus are all involved, and even you can appreciate a foci of sweep looming artifact, and it's more evident in the next slide, please. The left superior frontal lobule. It's in close proximity to the speech centers, as you can see. And the cuneus and precuneus are affected, and this may explain the visual field effect and the vertiginous aura as well. Please, the next slide, please. And as the patient is experiencing aura, aphasic aura and post-ictal aphasia, and due to the close proximity of the lesions to the language dominant, due to its presence in the language dominant hemisphere and its close proximity to the language centers, we performed a 3 Tesla fMRI for language. And you can see that the Broca's area is immediately posterior to the lesion, as you can appreciate here. Can you move to the next one, please? And this is. But the vernix area is appreciated bilaterally with no clear localization, and thank God it's away from the lesion. And for the motor fMRI, the right hand motor area, as you can appreciate here, that the right hand motor area lies away from the lesion in the left precentral gyrus, and thank God the same was for the left paracentral lobule for the right foot motor task. So if we are concerned with something here, it's the Broca's area, because it's like just in close proximity to one of the lesions. So taking all of them together, the clinical semiology pushes us to lateralize the seizure to the left hemisphere. The symptomatogenic zone puts us as Bonini 1, but as was previously discussed, the ORIS might indicate that the seizure origin might be far beyond the frontal lobe. It's a frontal lobe semiology, but it's not the very initial origin of the seizures because of the ORIS. The interictal discharge again points to left frontotemporal and more temporal localization. Taking into consideration that the electrical onset in the recording, in the ECTA recording, occurs much more earlier before the clinical onset, and thus we can conclude that the actual seizure onset zone is far away from the scalp electrodes. The neuropsychological evaluation is still pending. I would keep you updated about it next week, inshallah. And his MRI are showing bilateral lesions with more extensive left hemispherical widespread affection and smaller right temporal lesion, which I think it could be silent. And we didn't have PET done for this patient, and I want to hear your opinion about that. If you think that PET would help with something, and then we come to our question: which location within the left hemisphere is guilty? As we discussed, it's a Bonini 1 semiology, and this is the symptomatogenic zone. But is it truly pericentral generator, or it's a spread from posterior seizure onset zones. And I'm leaving the floor for all of you to hear the discussion about this case and have your insights.
Yeah, thank you, Dr. Shaima, as always, for the excellent presentation. We'd like to invite the Indian faculty to comment. Dr. Danesh, can you give us, we'd like to hear your thoughts on this case.
Excellently discussed, very clear. I mean, right from the history to how you discuss the case, and it's wonderful. And also the final, analysis, the hypothesis, absolutely perfect. And this is a beautiful way of discussing. I think you got all the points right. The hypothesis that we have to, this thing is that we have to, between the two hypotheses, quite clear that you have to have the hypothesis B as the hypothesis that you would like to prove. And there is absolutely no doubt. There are multiple reasons for that. One, history, vertiginous aura, you can't ignore that. Number two, that inferior temporal quadrantic field defect, again pointing out to the parietal. Number three is that in Bonini type 1, which is motor, premotor, it could come from behind. And behind means either parietal or occipital. In this case, it's parietal. So for all these reasons, I think we have to consider as the first hypothesis that this is a parietal epilepsy or a parietal or parieto-temporal epilepsy, which is then spreading to the frontal. That is going to be your first hypothesis. Obviously, you would, and that the only way, obviously, all these, the irritative zone or the spiking zone is predominantly, you saw these frontopolar spikes, a lot of them, in fact, in a periodic fashion, as you nicely described. They're frontopolar. And they're more anterior, but they also have a very wide field. You can see that the field is extending right up to the parietal also. And which is expected. And obviously, anything which is frontal and parietal, the temporal always will be involved. So it's a very wide irritative zone. Therefore, it is a multilobar epilepsy. It's unlikely to be a small area which is generating the entire seizure. It is usually, this is what is called a multilobar epilepsy. And we just now discussed about the temporal plus and all that, but this is not a purely temporal lobe epilepsy. In a temporal plus, the predominant seizure type is temporal, but it is not purely temporal. That is what is a temporal plus. The seizure type is temporal, but it has some plus features. Here, the seizure type is not temporal. The seizure type is frontal. So we are not considering here as a temporal plus epilepsy. So that's a very important thing. Although you've seen the rhythm that is coming in the temporal lobe and all that, but temporal lobe is always, any seizure that is extratemporal will also show a lot of temporal involvement. So that is how, because the temporal lobe is a very participative lobe. It would like to participate in all these activities. It may not be in the temporal, but the temporal would be the first person to say, yes, I am there. So it could be falsely lateralizing. But in this particular case, there are two things that tells you that you cannot ignore the temporal lobe fully. One is that there's a lesion there, which is in the temporal pole. Number two is that a posterior temporal can generate a vertiginous aura. So therefore, this is truly a multilobar epilepsy. We should think of the parieto-temporal, that is the parietal and posterior temporal, as the regions which could then go and spread anteriorly to the frontal and manifest as frontal. That should be the hypothesis. And in this particular case, there's absolutely no doubt that to prove that hypothesis, this is the ideal case for a stereo EEG. There's no doubt about it. Multiple lesions are there. And you know that there are, so out of all these lesions, the three important regions that you very nicely described are the frontal, the middle frontal gyrus, the basifrontal, then you have the temporal, then you have the parietal. The parietal is the cuneus, precuneus, and then the cuneus. And so therefore, you have to implant these regions and then have this hypothesis that yes, your primary hypothesis is posterior and then it going there. So you should have electrodes in the precuneus, cuneus, superior parietal lobule, inferior parietal lobule, temporoparieto-occipital junction, posterior temporal, temporal pole, posterior basal temporal, and then you have the orbitofrontal, the frontal lobe, the orbitofrontal. Then you have the perirolandic coverage, which is the leg motor, leg sensory, hand motor, hand sensory, and the SMA. That will be the kind of coverage. We can do it plus minus this way, that way, but that would be your coverage. And you can completely ignore the right side. I don't think you should even think about the right at all. Concentrate on the left. There's enough to concentrate on the left, and there's enough to prove for the left where exactly, which is the primary or the primary generator, and then how it is spreading, which network it is taking, and then formulate a resection plan. This is an ideal case. There's absolutely no doubt for a stereo EEG. Among all the cases that we have discussed, I think this is probably the best. This is my take on this. I would love to hear from.
Yeah, just a point of clarification, Dr. Shaimaa. I was just asking a question about your description of the patient's aura. You described it as the repetition of the patient that was repeating his own words as preservation, which implies more of a frontal etiology. The decision, but not you didn't say it was like verbal automatisms, like palilalia, which is more of a temporal origin. Can you give us like an idea about why did you choose to call it preservation versus palilalia or verbal automatisms?
Well, this is a great question. I had these conflicts in my own mind, and I could think of naming it. Is it truly a preservation or a palalia, like you just mentioned, or it's a verbal automatism? But the family are describing that the patient is keeping repeating the last word he was just saying. So that's I found that this is the definition of preservation, where he can repeat the same sentence again and again. It could go hand in hand to palalia. But I'm not sure if it's a verbal automatism, because sometimes verbal automatism are more likely to occur as sounds more than some sort of vocalization. Yeah, they can have words within, but sometimes it's out of context to what was going on previously. The patient is just repeating the last word he was just telling, and that's the preservation. Regarding the localization of the preservation, I'm not sure if it's truly, it can localize well either to the frontal or to the temporal. And as per our information from the aphasia syndromes, from the stroke, even you are having cortical types of aphasia or dysesthesia and some transcortical types. It's very difficult to just draw conclusion from the patient description without having these particular aura recorded in the EMU, which wasn't possible, unfortunately, across the 4 trials of getting him this habitual aura. And in fact, this was my a question for the esteemed panel. We didn't record any aura, and the vertiginous aura is not encountered by the patient currently. He was having it very initially when he first described the seizure onset, but currently it's just having this some sort of speech repetition. So I want to hear from you too about the possible type of dysphagia in this patient, and if we should have this aura recorded even before implanting him, or just we are going to have the implantation and then we try stimulation to reproduce all the types of aura, including the vertigo.
Well, yeah, a good point. But you said that for quite some time now he's never had an aura, and so that's something that I don't think you'll be successful in. If he's not had an aura for a long time, then I don't think you will succeed in recording an aura. So that I think is not required, is what I think. And
Let me
you very
clarify.
nice.
He's having aura in his habitual seizure at home, but in the
At home,
EMU,
he does,
yes.
is it? Okay, that's fine.
Yes.
I don't think you need to bring him back to just to record the aura. I don't think that's going to be different from whatever you have recorded. So I wouldn't really do that. It's not required, is what I think. But what is interesting is that you had the discussion just now about this perseveration, and you very nicely told about the fact that, you know, if you take the perseveration as a repetition, it's not a verbal automatism, as you rightly put, because verbal automatism, they would not in context, they would just keep talking something else. Not in the context. Here it is in the context because he just repeats the same word of the whatever last word that is spoken, and then he keeps repeating that, which is truly a repetition. And whether it is anterior or posterior, very difficult to know. Just like, for example, you have a transcortical motor aphasia where repetition is preserved, and that is very anterior. But you also have a transcortical sensory aphasia, which is actually more posterior. So that is very posterior. So it could happen anywhere. So in this context, again, you know, there's no escape, but you have to sample the posterior perisylvian region, which is the posterior temporal, and the supramarginal, the language cortex completely, and the lesions that are there. And I'm sure you'll be able to. And then you obviously have to have electrodes in the inferior parietal lobule, the superior parietal lobule, the precuneus. And I'm sure that when you stimulate, you would probably get the vertiginous aura, and you got to be, you could get, I mean, if you're lucky, you'll get it. And then the person may say, yeah, that's the kind of symptom that I get just before a seizure. So I think, I don't think you should I don't think you should bring him back and try to record a vertiginous aura. I think you should just go ahead and implant this patient, is what I think.
And may I have a question about the evolution of auras? Sometimes the patient are describing auras that they used to have in the past, but currently the aura sometimes change or even disappear.
Yeah,
Have they found something?
it just tells that, you know, the networks keep changing, in the sense that that's the thing, no, that as you wait for longer and longer periods of time, when these epileptogenic networks get either recruited, or a newer pathway comes, and then the older pathway is less used. So it's a very dynamic process, especially the trauma, post-traumatic, because you said that this trauma took place about 6 years back, isn't it?
Yes. Yes.
Yeah. So it takes about, yeah, so 6 years. So, you know, it generally, you know, in any say, for example, in post-encephalitic epilepsy, for example, we would like to wait for at least 5 years post-encephalitis and then only investigate for a drug-resistant post-encephalitic epilepsy, because it takes about 5 years for the
Dr. Danesh? Can you repeat the last minute because the voice was cut off?
Oh yeah, I don't know why it suddenly went into mute. I'm sorry about it. I was just mentioning that in post, you just take the analogy of post encephalitic epilepsy. After encephalitis, acute encephalitis, whatever be the cause, and if you want to do a surgery for drug-resistant epilepsy post-encephalitic, we've been always taught, and that's very true also, that you've got to wait for at least 5 years, because it takes 5 years for the networks to kind of stabilize and become kind of with a certain pattern. Till 5, things are unstable. The networks can keep changing, and symptomatology can keep changing. So you should not chase them early. As absolutely the same with this post-traumatic. And so here, this person is now into the 6th year after his trauma and seems to have settled into a particular pattern. And that's the reason why we were discussing that, he's had these kind of auras. Now some auras are there, some are not there, and all that is all because of this. It takes a little time for it to settle down into a particular kind of a network. And I think now it is 6 years, and you can now safely and confidently go ahead and investigate for which network is clearly involved, and then you can actually intervene at this point. Supposing we were discussing the same patient, say 3 years ago, I would be hesitant. I would say that, okay, I would like to wait for some more time. Just like in the first case, we were saying now, we would like to wait for some time. Let's see what happens. So the same thing we would have discussed. If we had discussed this patient 3 years ago, I would have said, oh yeah, I'm going to wait for some more time. I would wait for another couple of years. Now, this patient does not have to wait. You can just go ahead because you waited long enough. 6 years is a good enough time for a post-traumatic epilepsy to kind of stabilize. Just go ahead. Yeah, that's my take on this.
Thanks a lot, Dr. Danesh. If anyone wants to ask a question, you can go now. Okay, so to quickly summarize this second case, presented with a bilateral post-traumatic lesions, and the key challenge was determining the dominant focus. And Dr. Danish here said basically that this case is the ideal SEEG candidate. So yeah, that's the case. And yeah, but before we close, we like to recognize Dr. Ludi Wagner, the clinical director of Dexy Medical. She's here with us in the meeting. We are grateful for Dexy Medical for their support for bringing SEEG to Egypt. This is and making this like historic program possible. We'd like also to thank our presenters, Dr. Ahmed Al-Qiyai and Dr. Shaimaa Shaban, for preparing 2 great cases. We learned a lot from them. To our esteemed Indian faculty, Dr. Danesh, Professor Natation, and Dr. Arun, for sharing your incredible expertise and guiding the discussion. Obviously, to our Egyptian faculty panel, especially Dr. Ana Abdel for enriching that discussion, and for everyone in the audience as well. This concludes our second multidisciplinary team meeting. We look forward to seeing you all at the same time next Friday for our final online meeting in the series. Thank you and good night.
Thank you. Thank you very much. It was a very enjoyable meeting. Thank you
very
so much.
Thank you
Yeah.
very much.
Thank you so much, sir.
Thank you very much.
Thank you. Thank you. Thank
Thank
you.
you, everyone.
Bye.
Bye.
Good discussion. Thank you.
Goodbye.
Bye-bye.
Bye
Good
bye.
night. Good evening.
Thank you very much for all you.